If we think about complete dentistry, again, I'm no different than anybody else. You know, we should do a comprehensive exam, and the doctor and patient should have a clear understanding of every problem that should be treated. At least that's what we aspire to. I fall, you know, miserably short of that at times, as do all of us, but we aspire for the best for our patients and ourselves. Dental disease, it's a progressive disorder that will cause increased problems if not detected and treated in a reasonable time frame. The factors of dental disease, microbial, you know, periodontal disease, caries, we won't even go into that tonight, but I want to focus on on biomechanical and just bore you senseless with occlusion stuff. And it's a different view of occlusion perhaps than we were exposed to, certainly than I was exposed to in dental school. Biomechanical involves teeth, the periodontium, muscles, and especially the temporomandibular joints. Biomechanical components, we want to look at TMJ stability, functional occlusion, and parafunctional activity. And out of those, I'm gonna obviously center on TMJ stability because I think it controls the other two. Here's a case where we have, you know, functional occlusion down here. We certainly have evidence of parafunction and parafunction here. And this is an MRI of a joint in the open position, and this is the condyle, and this is the ear canal. The brain's here, fossa, eminence, and that's remnants of a disc. So that's a disc should obviously look a lot bigger. We have bone against bone here, and obviously, you know, God never intended bone to be against bone. I mean, the disc should be tethered to the head of the condyle and move when we move. So I'm going to throw out a couple of premises. You may tar and feather me or whatever, but I want you to just open your minds up and begin to think that this stuff isn't caused by stress. You know, it really isn't. So just we're going to answer that question later on. Some basic terminology, and I'll bore you with just some very basic terminology. People say, "Do I have TMJ?" Well, I hope to God they have two of them. You know, that's like you know, if you have knee damage, you go into the orthopedic surgeon and, you know, you have a torn ACL in the right knee, and the diagnosis he gives you is you got knee. So I mean, it's pretty much, you know, equates. You don't have, you know, TMJ. And we call it TMJ syndrome. Well, the definition of a syndrome is something that cannot be diagnosed by laboratory studies, imaged or otherwise measured by whoever it is looking at it. A disease, on the other hand, is an entity that must be defined through imaging, laboratory studies, or other methods of measurement. Well, we have that capability now with temporomandibular joint damage or disease of making an accurate diagnosis. But disease, we can have general homogeneous disease, and that treatment is often generalized. Generalized treatment protocols don't necessarily assure success. And then we have disease as a heterogeneous set of subgroups, and this will get more interesting as time, give me a few minutes. Individually defined entities, individualized treatment modalities with disease as a heterogeneous set of subgroups. However, it doesn't make a daggone bit of difference if you only have one treatment to offer patients, what the diagnosis is. Biomechanical factors of dental disease can and will lead to failure of dentistry, including implants. Here are three various situations where dental implants have failed. It could be a matter of, and I think it's a matter of force. It's an unstable system, pretty poor planning, failure, and sub-engineered. It's a matter of force. You know, implants do very well with compressive force, lateral forces not so well. We've all had those patients. Pete Towson says, you know, if the TMJs are not stable, the occlusion will not be stable. So it's a risky proposition to undertake occlusal changes without knowing the condition of the TMJs. Back to April. Everybody sees the midline of the chin, the deviation. And again, these photographs, we're going to get some more information. We're going to get some scans. Scans are a great way to see inside. A scalp view on a CAT scan. You know, again, a CAT scan, and we're all very familiar with CAT scans now, especially with the use of cone beam CTs and in implant treatment planning and whatnot. But Things that are the whitest on a CAT scan, it's like a radiograph. Things that are the whitest are the most dense. They're the hardest. You can see the deviation. If we look at her right condyle, that's a fairly normal condyle. That's a coronal view, and this is a sagittal view. The ear canal's right here. Now look at the left side. Doesn't quite look the same, does it? Look at the left side here. Here's bone against bone with that spicule sticking up, but it's about half the size that it should be. Which way was her jaw deviating? To the left. That makes sense. An MRI. I did an MRI on her too. MRI is a different beast, and I'm sorry for this being a little bit grainy. An MRI, structures that are the whitest are structures that only have water and or fat in them. So an airway, well, it's an airspace, it's going to be black. The hard, dense cortical bone of the cranium, not a lot of water and fat in hard, dense cortical bone, so it's going to show up black. Soft tissue structures, the tongue, the floor of the mouth, well, a lot of water and fat there. Brain, a lot of water and fat there. The brain stem, spinal column, a lot of water and fat in those structures, so they're going to show up later. An MRI, I have the radiology tech take several different views. In an MRI, a T1 view is a fat-weighted view. T2 is a water-weighted. If you combine the two, you have something called proton density, and that's what we're looking at here. I like it because it gives me the most contrast. A stir image is a suppressed T1 resonance, so we're suppressing the fat signal, which means we're enhancing the water signal. So I use this to look for inflammation and effusion. Effusion is the difference between inflammation and effusion, as everybody know. Inflammation is fluid buildup within a tissue layer. Effusion is between tissue layers. So if it's in the joint space, it's effusion. This is April, the one we just saw with the canted jaw. This is her right joint, and you know, when we're looking at MRIs, you know, the nice little focal point is the ear canal. You know, the more medial we are, you know, the ear canal is like a funnel. It gets wider as we get out to the lateral or external surfaces. So this is medial. The ear canal is right here. Here's the condyle. Now remember, here's the brain right up here. Here's the fossa. This darkness right up here is the bone. It's the ceiling of the fossa. This is the eminence. The dark outline of the condyle is the hard, dense cortical bone, and we have the bone marrow. Now, our disc, you know, just is an amorphous blob. Cartilage is an amorphous blob, doesn't have water or fat in it, so it shows up black. This is the lateral pterygoid muscle. This is the inferior belly, this is the superior belly, and you can literally, it's beautiful. You can see the muscle fibers coming in, and of course that's the muscle responsible for us being able to open wide, grind left and right, and protrude straight out. So it's the major player. It's the one that causes all of our difficulty. And don't think we can palpate it. We can't. It lies too deep. So we have to palpate it by intent. And how I do that is I press in on the patient's chin and I have them protrude out. We count to 10 slowly and see what their response is. The muscle we always thought was the lateral pterygoid muscle. When we took our little finger and we hooked it up there, it's actually an insertion of the temporalis muscle.
I figures.
Anyway, this is April's right side. Well, you know, we saw on the CAT scan her condyle looked pretty good. Medial view, here's the disc. And if we look at this as a clock face, 12 o'clock being straight up, the posterior band should be in the 12 to 1 o'clock position. And I'm delighted if it's in the 12 o'clock position. That's normal to me. Laterally, here's her disc, and it's in the 12 o'clock, that posterior band's in the 12 o'clock position. So that's great, it's pretty normal. Here she is open. You know, the condyle vacated the fossa, here it is at the crest of the eminence, and there's the disc. Can you all make this out? Okay. Stir image. Now, even though everything is normal, relatively speaking, in the right joint, we see fluid or inflammation in the lateral pterygoid muscle. Okay. left side? Well, medial. Here's the condyle. You see a break, and you don't see the dark cortical plate up there. Well, we saw all the erosion on the CAT scan with April. Here's the disc. Here's what's left of it. Now, in the sagittal section, a cross-section of the disc should look like a stereotypical dumbbell. You know, it's biconcave in the middle. It looks like a roll of hard candy cut in half. And, you know, that old adage, you don't use it, you lose it. John exercises all the time, so he still has it. But those of us that don't, lose it. And the disc is no different. If it's not in function, it begins to shrivel up. So you see a very small disc. And that gives you a clue into timing of the damage. How long has that been damaged? Well, it didn't happen overnight. You know, she's been experiencing symptoms for 4 years, and chances are, that left joint was damaged long before the 4 years. And let's look at the left side open. Here's the disc right here. So it's being pushed out. It's not reducing. It's being pushed out into the lateral pterygoid muscle. So we certainly would expect to see some We'd expect to see some inflammation in the lateral pterygoid muscle. Well, we had it on the right side too. We have a bit of a fusion. So that white signal right there is a fusion in the joint space. All right, so now we have that information, we look at this a little differently. I mean, basically, it's a crime scene, isn't it? There's a reason why all this stuff happens. There's a reason why teeth break down. John, you still hot?
Yeah, I try to. I mean, not as much as I used to or would like to, but.
Well, this is why ducks get shot in the fall. Duck is giving a warning to the bass. There's bass fishing over there. Anyway, let's look at another case. This is a gentleman, wonderful guy, who's 60 years old, and I just don't deal with left joint breakdowns. You see the deformity. He's also deformed. He's also asymmetric, and you can see the midline of his chin is deviated to the left side, and you see this masseter swelling in here. Close-up view of the masseter swelling and how far off the midline is. You can see he's a bit retrognathic. Smile, very pleasing smile. But there's his occlusion. So he also is deviated. You think it's a tooth problem? The open bite. And if you look at all the dentistry he's had done in the posterior segment, and that's failing. Again, there's a reason why his teeth fractured. There's a reason why his teeth wore. You know, was it a tooth problem? I personally think that teeth are innocent bystanders in many of these cases. You can see all the back teeth have been crowned. If we look at his, now I did not get an MRI on this gentleman because he is so claustrophobic. He absolutely refused, even with medication, to have an MRI done. This is a cone beam CT, and you can see the right side. You know, the condyle looks fairly normal. Well, what's happening on the left side? You know, he's asymmetric for a reason. We look at the left condyle. It's bone against bone. It's reduced in size by about a good 50% versus the right side. And the right side's a little damaged too. You see a little bit of lipping, bird beaking is an osteoarthritic appearance. This view, you can see, this view on the cone beam CT, you can see his open bite. You know, these are the central incisors, upper and lower. You also see airway's a little bit narrow here. You know, I'd like to see a little bigger airway. This patient did have surgery, actually. I did send this patient for surgery, for a surgical consult. Ed Zibovitz, who practices down at Bowie.
Sure, no, Ed.
And, yeah.
For TMJ or for the
Yeah.
for the retrognathia?
Or
for both?
Well, for both, but I'll show you what happened. And this is mounted on on a SAM articulator called an MPV, which allows for condylar distraction. And this is prior to, you know, if orthognathics is planned, make sure the joints are stable first. Otherwise, you read all the literature about orthognathic cases unraveling and relapsing, and you know, chances are the reason they relapsed were the joints are never stable. So, on this, you know, corrections can be made in millimeters. You can adjust the condyles on this articulator to get an idea of how much distraction has to take place. I got him stable with an orthotic appliance that he wore 24/7. He absolutely loved me for that. I made an upper for him instead of a lower because of the retrognathia, the slight retrognathia. The upper works better in those last two cases. Otherwise, I'll do a lower. The lower is easier to adjust, far easier for a patient to function with. But you can't do it in that case. And this is now 7 months post-op. What Ed did was a fat graft. He did a meniscectomy on the left side and took fat from around the navel and placed it in the joint space. That correction, that fat, he overcorrects it. The patient is maintained in elastics for about 9 months. It takes 9 months for that to mature. The fat will coalesce. The nice thing with fat is it reduces adhesions in that joint, and you know, it's an incredibly viable tissue. I mean, let's think about how hard it is to get rid of fat. I mean, the stuff just lasts and endures. It's wonderful stuff. Mark Piper, Dr. Mark Piper, down in St. Petersburg, Florida, pioneered this technique, doing fat grafts probably 18 years ago. So it's not a new technique. His statistics of success and retention in a joint are about 96%.
So he does a meniscectomy and
yeah,
fat graft.
Yeah. Let's get rid of the disc floating around. It's an irritant. And he does the fat graft. This is his occlusion. 7 months post-op. Now it's not ideal. So what I did is I mounted his models on a SAM articulator, and I did a trial equilibration on the articulator, and there we are. So the question was, I can deal with this crossbite back here. I don't really care, but that's what we're going to do with him. It's just equilibrating now. And so here's a case I really thought was going to need fat graft and orthognathics, right. And it's amazing sometimes what you can get with just a fat graft.
How's is he feeling better? I mean, the pain is gone?
He is. The swelling's gone. Yeah, he's I had him very comfortable in the orthotic, so he has an option now. He can wear the orthotic 24/7. And, the orthotic, the purpose of the orthotic is I'm tricking the muscles with this orthotic. Now let's think about, I'm going to get ahead of myself, I guess. But just keep in mind that with the orthotic, that's a means to an end. Most of these patients, even though they have, torn up joints, most of their pain is muscle in origin. It's really, muscle spasms. Well, why? Because God designed the system to work a certain way, and we're going to get into that. But it's not working anymore. No fault of the teeth. It's not working anymore because of joint damage, joint breakdown, joint disease, not joint syndrome. So the orthotic is a means to an end. I have not done the final equilibration on him yet. I'm going to wait till after the 9 months, which is coming up in about a month. Yes, sir.
What are the brackets for?
Elastics.
The holding
Elastics.
Forward.
He has a post-surgical stint, another orthotic that Ed makes himself, he's in that, and he has just inter-arch elastics. Takes him out to brush, takes him out to clean. All right, here's another patient. This patient was 15 last year, and again, facial pain, bilateral facial pain. She is post-ortho, and the orthodontist, wonderful orthodontist in the area, sent her over for an evaluation. She said, I think something's going on with this case. Right and left CT, you can see that the right condyle is pretty normal size. The left condyle is a little smaller. If damage happens to this joint, prepubertal damage, when that joint's still growing, that condyle typically is not going to grow to its full extent. It's something called, excuse me, osteochondritis of childhood. So do you think that's going to cause an asymmetry issue? Sure it is. Sure it is. Also, that disc, I'm suspecting something going on with the disc here because that condyle is posterior in the fossa. Do we expect occlusal changes with that? Gotcha. All right, this is her. I mean, she's a very pleasant young lady, and this is her right joint, medial and lateral when she's closed, and here she's completely off of the disc. Here's her disc right here. Lateral view, here's her disc right here. Left side, here's her disc on the medial. Here's her disc on the lateral. She has a little bit more bulk of disc medial. Interestingly enough, if it displaces and it's more medial than lateral, I'm a little bit more concerned because most of the blood supply coming into that joint is coming from the medial aspect, and that displaced disc, it's a big juicy disc, and it's a medial anterior displacement, that can cut the blood supply going into that joint, and we've got a nutritional issue. Here's the stir image. Everybody now knows that's a supercharged water view, so we're looking for inflammation and effusion. And here's some inflammation in the right lateral pterygoid muscle. Here's the disc, here's the condyle, there's the ear canal, the brain, lots of water in the brain. Left side, we've got, this is a different view. It's a little bit more lateral, so we're not picking up all of the lateral pterygoid muscle, but here's the displaced disc, and here's effusion around that displaced disc, and that's effusion or fluid buildup in the superior joint space. Not surprising. Here she is open. Right side, she doesn't recapture. Left side, she doesn't recapture. And here you can really see the difference in size of the condyles. Pattern orthotic appliance, 24/7 wear, or, for a 15-year-old, as much as she could do it, or would allow it. But she was pretty compliant, because as she wore it, and I would see her periodically to adjust it, because as muscles relax, as joints remodel a bit, and they will remodel, the bite's going to change on this. So if I just give it to her and let her go about her way and say, hey, enjoy life, it may work for a week, and the bite's going to change. So you have to be vigilant. You have to keep up. You have to, and the way I adjust these is ideal occlusal principles. Ideal anterior guidance is what I build into this, because you got to think, how's the system designed to work, how the muscles work effectively. What controls the musculature, and it's our anterior guidance, really. It shuts off the muscles of the system. Just a case in point, everybody clench. You clench really hard, 800, 850 pounds per square inch. Now put your teeth out edge to edge. Try to clench. Brain won't allow it to happen, will it? The front teeth, the anterior teeth, literally act as the governor on the engine. It literally shuts the musculature off. So that's why anterior guidance is so very important in the system, because of the protection. You don't have anterior guidance, you have posterior interferences. EMG studies indicate at least triple the amount of muscle force is exerted if those posterior teeth are in interference, if they drag along each other. The muscles have to stabilize the jaw in that position, in that motion. So that's what I build into the orthotic. Okay, here she is, post-orthotic, and she is pre-equilibration, but I sent her back to the orthodontist, and we corrected the position of these two molars. She corrected the position of those two molars a little bit to make it easier for me to equilibrate. It took a couple of months. Everything worked well. But you can see we're far from having ideal anterior guidance. We don't even have anterior contact. All right, here she is post-equilibration, and equilibration isn't always subtractive. It can be additive, and I did the best I could. If we look at this photo, this is composite added to the back of the cuspids and the back of the laterals to give me some contact. There's no way in God's creation I could get the centrals in. Why? When you think about what her condition of her joints look like, you know, she's not on the disc. So that disc has some volume. You know, two things can't occupy the same space at the same time. So if that disc is anteriorly displaced and the condyles are positioned posterior to the fossa, well, what the heck do you think the condyles are attached to? Is the lower jaw. So what's happening? My shoulders are the temporomandibular joints, and she's off the discs, and the condyles are seated up and back, and my arms are her lower jaw. What's happening? Well, as the condyles seat up and back, the mandible comes up and back. So we have an anterior open leg. And that's what happens. So I hope you all are beginning to think about these things a little bit differently now. Here she is in right working and left working with canine guidance, and she's stable. Now she's just in a sleep time bite split. You know, I apologize I couldn't get this, but my God, unless we added a gob of material to the bell of those centrals, then we've got a speech issue. So you know, we do the best we can do. You know, and sometimes we just aren't looking in the right places.
Photoshop, right?
I have no idea. I got this off the internet. I thought it was hysterical. All right. So to understand disease, let's real quick run through. We're going to give you guys a refresher course in anatomy, what happens with healthy joints. A beautiful book by Parker Mahan. Parker Mahan unfortunately passed away 2 years ago. He was one of the most brilliant people I had ever met in my life. An amazing man who was at the University of Florida, ran the Parker Mahan Facial Pain Center, and then Henry Grimion took it over. And since they changed deans, and the dean had a torch and burn attitude at the University of Florida, they closed down what I thought was the finest facial pain center in the world. And Henry Grimion was immediately picked up by LSU and is dean at LSU now. But here's normal anatomy. You know, here's the earlobe. You remember all those things we saw in the MRI: condyle, disc, lateral pterygoid muscle. Centric relation. You know, the most superior position against the eminentia, irrespective of tooth position or vertical dimension. Not really the most superior position, but the most superior medial position. I talked to Dr. Anthony Hamad about this. One of the most frustrating things is I had some of these slides on PowerPoint, and I have this MacBook, and you know, not everything kind of pulls over equally with the MacBook, so you know, forgive some of these slides. So anyway, centric relation. You know, the condyle is braced medially and superiorly. It's the midmost position. Form follows function. You know, let's look at a CT scan. Where's the bone the thickest in the joint? Medially. That's where all the load is. When we're closed. When we're closed. It goes to the lateral pole as we open. Coordinated muscle function. You know, we have all these vectors of force: the temporalis muscle, the masseter muscle, the medial pterygoid muscle, and that positions the condyle. I mean, it's just a matter of anatomy. Ideal occlusion centric. You know, we have dots in the back and lines in the front. Determinants of occlusion. The joint anatomy. You know, what conditions the fossa in, what conditions the condyle in, where's the articular disc, what positions it in, and then there's muscle function in tooth position. So you got to think of it comprehensively. Maybe more than teeth. You know, when we're born, we don't have any teeth, but we almost have a completely fully formed temporomandibular joint. So, should it be a tooth-based occlusion or a joint-based occlusion? vote for joint-based occlusion. Temporomandibular joints differ from other joints in our body in two different ways. One way is how it moves. It rotates and it slides or translates. Ideally, here's the disc, the retrodiscal tissue. When we begin to open, the anterior digastric contracts, and for about the first 15, 20 millimeters or so of opening, it's strictly hinge motion. In order for us to open wide, the lateral pterygoid muscle fires, and it's the inferior belly primarily that brings the condyle forward. The bit of the superior belly does fire because it brings the disc forward with the condyle. And that's how we open. And an interesting thought, why do we translate? Why does this joint have to do that, unlike any other joint in our body? Because if we open on a strictly hinge axis, and everybody do that right now, try to hold yourself upright and try to open on a hinge axis, what's happening to your airway? This is God designed the system exquisitely because it gets the mandible out of the way, that we can actually still breathe while we talk, while we chew, while that jaw functions. It's an incredibly designed system. When we close, there's three main closing muscles. The temporalis, the masseter, 3.5. The medial pterygoid, and then part of the superior belly, the lateral pterygoid, stays contracted to ease that disc back. And then it seats, it reverses the process until all the teeth hit evenly, and then the muscles get a chance to relax. So, just go back, please. So what happens in our joint damaged patients? They don't have a disc here. It's displaced. So the condyle seats up and back. Do we think the bite's going to stay the same or change? It's mechanically impossible for it to stay the same. Absolutely mechanically impossible. So what happens when you deprogram those muscles? And you can do it with 2 cotton rolls and just have the patient relax for a few minutes, and then just to see if that jaw relaxed. Just tell them, when our jaw's relaxed, it's like it flops like a hinge. That jaw flops like a hinge, and it just close ever so gently with the lightest force, and tell me where you hit first. And they'll hit on one side or the other in the back first, and then slide into maximum intercuspation. These muscles exert at least much force per square inch as your leg muscles. And if all that force came to bear on the last 2 teeth on April's mouth, for example, in the back left, she'd experience a tremendous amount of pain. So the brain tells the muscles, hey fellas, you can't close this way. I know you want to close that way because, any muscle that has a contraction phase has to have a relaxation phase. But you can't, because if you do, we as an organism are going to experience a lot of pain. So that's the difference between your anatomic bite and your acquired bite. They're functioning out here. Well, no wonder why they have muscle pain. Most of their pain is muscle presentation because those muscles never get a chance to relax. What happens to a muscle that never gets a chance to relax? You get a Charlie horse in it, goes into spasm. So, that's what I'm able to do with the orthotic. I'm sorry, I didn't know I reversed it that much. Second way the TMJ differs from any other joint in our body is the right side's connected to the left. They're just opposite ends of the same bone. Can't move them independently. So don't think you're going to get through life unscathed with damage in one joint and the other joint's going to be fine. I do see it. We saw it with April. Her right joint's pretty normal, even though the left joint's shot. This is a case actually of a deformity, a jaw deformity due to forceps delivery, believe it or not. This guy's a year younger than me. It's a metagnathic system. There are 3 points of contact. There's the bite. That's one leg of a 3-legged stool, and then there's the right joint and the left joint. So we saw an inch off of one of the legs of the stool and expected to set level. It's just not going to happen. Back to April again. We know what now has happened to her left joint. No wonder her bite's off. No wonder and it's really more jaw position off than bite. We'll make her an orthotic appliance. We'll go through that. April will have to have a well, one of her options, you know, my first responsibility is that of an educator. I got to tell the patients what all their options are. She will have, you know, a surgical consult is one of her options. Sometimes we feel like we're the hunted, don't we? It's a case, parafunction. I'll tell you, it's my brother. It's tough working on family. And here you go, my God, you know, he's in a stressful job. Well, yeah, but that's not really the cause of this. There's a severe amount of wear, occlusal instability. But you look at his CAT scans, and look at this. I mean, this is a long-standing damage. The right joint actually is pretty stable. That bone becomes sclerosed, uvenated, and pretty stable, almost marbleized. Left joint still actively breaking down a bit. Here's an inclusion cyst. There's some active osteoarthritis going down. You know, you look at his mouth, and there's a reason why he's got all these crowns and some root canals, and there's a reason why he's missing a couple of teeth up here and has implants. You know, the right side broke down first. You know, the right side dentition broke down first. It's a force issue. You know, you look at curvus B and curve of Wilson. You know, what actually are we looking at when we look at the curvus B and curve of Wilson? You didn't think you were going to hear this again tonight, did you? Tough. Anyway, curvus B, you know, you can read all this, but basically, you know, on average, you know, if you take a point midway through the condyle, it's about you know, you take a 4-inch arc, and roughly most of the population falls on that line. And teeth are lined up that way because of they're in the long axis with the amount of force that's distributed on them. So, with Bill, with protrusion, what do you think this condylar guidance is doing? Pretty flat. Certainly not 40 degrees anymore, or 35 degrees, or anywhere close to it. It's pretty flat. So he's going to have some anterior wear. You know, there's a reason why all that wear occurs. Curve of Wilson, left to right. You know, the purpose of the curve of Wilson is force distribution again of mastication. It forces food in towards the tongue. But what controls the shape of these posterior teeth buccolingually is really our lateral guidance. And again, you know, that's all condylar. So with TMJ damaged folks or diseased folks, their occlusal changes, form follows function. You know, curve of Wilson changes, curve of speed changes. You know, you can't separate temporomandibular joints, and they're really the culprit. So how do you go about restoring somebody like this? You have to gather information. You have to verify stability of the system. Again, an orthotic appliance is great. You know, have them wear it. If they wear it for any length of time and you adjust the bite on the orthotic, ideally, you'll see grooves, worn grooves in there, and you can take that, make a custom incisal guide table on an articulator with their orthotic appliance. I mean, because all the condylar guidance is in the orthotic appliance. They've worn it in. You can do a diagnostic wax up. Next time you see Bill at the lab, ask him to smile for you. Composite overlays were made up. I had to reduce some of the lower teeth to change the effective guidance. That's the reduction guide. Did a functional mock-up. This is composite, actually, that he swore he was going to break off, and he didn't. That was on there for the better part of a year. You got to respect the anatomy. That's where he was before. This is composite mock-ups, provisionals. That's before and after with Bill. Since then, his left joint's still breaking down a little bit, and I've had to adjust the incisal edge of that right central. Well, you know, that's what you'd expect if the left joint is breaking down. You know, what causes wear on the right side as we go into a right side working? You know, the left joint's the one that's moving, the right joint's the pivoting. So, our objectives, you know, understanding the factors of dental disease. Is occlusion really joint-based or tooth-based? And I think it really is joint-based. I mean, the teeth are innocent bystanders.